Well, I would like to thank everyone for inviting me. I spent some very happy days, months, and years here at Harlem Hospital as an intern and as a fellow. And I've learned about the work of Dr. Gerald Thompson, and in honor of his great work here at the hospital to benefit not only the patients here, but mankind in general, in honor of his legacy, and also in honor of all my fellow interns and residents during that period, I'm here. So when I was asked to give a presentation as a part of the theme, I thought about how can we improve the ophthalmic care of the elderly, and the answer is to prevent blindness. And then the next part, how do we prevent blindness? Well, I developed a concept of community ophthalmology, believe it or not, while I was at Harlem Hospital. So, as I said, part of the legacy is my squad, my posse, my friends and alumni at Harlem Hospital. So I believe I'm the only person here from 1968. We were a product of the 60s, you know, the whole civil rights era. You know, we entered medical school in '64, the year of the Voting Act, and we were part of a group of people who wanted to change medical care at Harlem Hospital by making it a center of excellence, and Columbia led the way when they agreed to affiliate. That's me there, different hairstyle and color. And that's Lucy Rockefeller and her husband, Jerry Waletsky. You know, we were part of that team. So after I did my internship and I wanted to become an ophthalmologist, my residency slot wasn't ready, but Dr. Jose Ferrer gave me a fellowship. So I was a Harlem Fellow between Columbia and Harlem. Why? Because there was not an eye clinic. There was no eye clinic at Harlem Hospital back then. There were only a group of optometrists and opticians who cherry-picked the patients and sent them elsewhere for surgery. But there were no ophthalmologists. And you can imagine how much I cried, how much that hurt me, wanting to become an ophthalmologist and take care of people, and then coming back to my Harlem community where I was born. So I wanted to start an ophthalmology program, and of course my mentors at Howard University said, hey Pat, you can't do that, you're not an ophthalmologist yet. But I wanted to begin the process of bringing quality eye care to Harlem Hospital. By force of nature, destiny, and personality, I was able to convince members of the eye department at Columbia to come on down. And I'm happy to say that we were, through the cooperation of Columbia and the hard work of my colleagues, we were able to do token things. You know, obviously we couldn't do cataract surgery because who was going to follow the patient? But we were able to get the ball rolling, to increase visibility about the problem, and we did the first eye surgery there. That's the op report. So, getting back to the theme of this program, when we want to improve the elderly, the eye care, we must recognize the major causes of blindness among the elderly are cataract, macular degeneration, diabetic retinopathy, and glaucoma. And of course, In these United States, we're going to say elderly is over the age of 65. However, WHO changes the definition depending on the geography and the geopolitical climate. Cataract. So, in the United States, there are 24.4 million individuals with cataract. Normal eye with cataract, and keeping with the theme, a black patient with cataract. Macular degeneration is the next most important cause of blindness among the elderly. 11.2 million with age-related macular degeneration. These are examples of drusen, absence of the pigmentation. They have macular thinning, and there are two types of macular degeneration in general of this age-related, the wet or the dry type. In the wet type of AMD, you have some neovascularization, fluid, and this can be treated with laser photocoagulation as well as some anti-angiogenic drugs. Diabetic retinopathy is also a major cause of blindness, as you know, among the elderly. I assume that most of the people that I'm speaking to are not ophthalmologists, but hopefully in your practices, you will refer your patients who are complaining to you of poor vision, difficulty reading, seeing spots before the eyes, photophobia, etc., to an ophthalmologist. And of course, this is, I think, a beautiful, more or less stylistic, almost animated type of image showing in the proliferation of abnormal vessels. Of course, aneurysm is the basis, microaneurysms, and the non-proliferative or the proliferative type. Now, we're going to spend a lot of time talking about glaucoma because this disease has a predilection for African Americans. 2.7 million, and by the way, we can get the video ready? Okay. 2.7 million Americans have glaucoma. This is the normal optic nerve head, and remember, it's usually the cup to disc ratio and the vertical disparity, generally over 0.3, which is an important hallmark to look further, to do more testing for glaucoma. Here's an example of glaucomatous cupping, and this diagram shows the progression of cupping due to elevated intraocular pressure in glaucoma. So now let's have the eye video. And I thought this video would be helpful because it will refresh and review what's entailed in a dilated eye examination.
The comprehensive dilated eye exam, opening the door to preventing blindness. During a comprehensive dilated eye exam, the patient receives special eye drops that dilate the pupils. The pupils open wide, allowing the doctor to see the back of the eye clearly. With a better view of the back of the eye, the doctor can look for signs of the common eye diseases that can lead to blindness: glaucoma, diabetic retinopathy, and age-related macular degeneration. When eyes are dilated, the doctor can clearly see the retina, optic nerve, and the macula. This is the optic nerve. The doctor is looking for early signs of glaucoma. This patient's optic nerve is healthy, But here's what it would look like if it showed signs of glaucoma. The doctor will see changes in the shape or color of the optic nerve. The doctor may also see what is called cupping of the optic disc. Glaucoma is most common in African Americans over the age of 40, people over 60, and in people with a family history of glaucoma. In addition to the optic nerve, the doctor can also clearly see the retina at the back of the eye. The doctor might see signs of diabetic retinopathy. Early diabetic retinopathy starts with small red dots called microaneurysms and can progress to leaking blood vessels, causing thickening of the retina and blurring of vision, or new blood vessel growth that can bleed and cause blindness. If you have diabetes, you are at risk for diabetic retinopathy. While still examining the retina, the doctor can also look for signs of age-related macular degeneration, or AMD. If this patient had AMD, the doctor would see yellow spots beneath the retina, called drusen, or dark clumps of pigment. AMD is the main cause of visual impairment and blindness in older Americans. Dilation enables doctors to get a better view of the back of the eye, which allows them to determine whether there are early symptoms of disease. But it's important to know that all people older than 60 need a comprehensive dilated eye exam each year and should inform their doctor right away if they begin to have problems with their sight.
While we're doing that, may I ask, are there any nurses here? May I have a nurse volunteer? May I have a nurse volunteer to come forward?
Go to the next slide.
Yeah, yeah. Yay! And are there any social workers here? Any social workers? May I have a social worker volunteer to come forward? Well, I want to mention that I learned a lot from the nurses while I was an intern here at Harlem Hospital.
Right.
We got to listen to them.
That's right.
And my brother was a social worker. And so we're going to move on and talk about the major causes of blindness. And, you know, we're part of a team. It takes a village. Community ophthalmology is a multidisciplinary team. And that's why I've asked for a couple of volunteers to help me hammer through certain points.
That's right.
Okay, so just to review again, as I said, I want to spend time here talking about glaucoma because glaucoma is the leading cause of blindness in African Americans. And we're talking about African Americans in this community who are elderly, and so we have to come to grips with glaucoma. The other important thing I need to say to the nurse practitioners, the family practice doctors, the social workers, the home care providers, and may I ask you to read that first sentence?
Among those with glaucoma, 78% were previously underdiagnosed and undertreated. Blacks have roughly 4.4 times 95% confident intervals.
Okay, thank you. And the important thing is, this is undiagnosed. So as the ophthalmologist, I won't even see this patient. So it's important for the primary care providers to be suspicious, to consider the risk factors. So how do we prevent blindness? Ms. Social worker or nurse? Go ahead.
Determine risk factors. Risk factors for glaucoma: race, age, sex, and genetics.
Okay, what is community ophthalmology? Remember, my whole mission here is to prevent blindness, and I can't do it by myself. I realize that in order to prevent blindness due to glaucoma, you need the whole team. And community ophthalmology, which had its beginnings when I was an intern and fellow here at Harlem Hospital, because there was no eye clinic, and I noticed all these blind people here at Harlem, and when I go to Columbia, very few at the Charles DeVoe Harkness Eye Institute. So in order to prevent blindness, we need community ophthalmology to promote eye health, blindness prevention through application of the methodologies of preventive medicine, public health, and clinical ophthalmology. And the most important part here is screening. And when we do screening, we need the physician's assistant, the ophthalmic assistant, the nurse, the social worker, who knows why the child is not seeing in school, or who knows why mommy or daddy needs, or grandpa or grandmother needs a pair of glasses. And we need eye health education, and hopefully telemedicine. So community ophthalmology also employs the concept of primary eye care. And the basic health services, sometimes called public health services, classically include nutrition, maternal and child health, family planning, environment and sanitation. But let's add primary eye care, because there is avoidable, preventable, excessive rates of blindness among African Americans in general and the elderly in particular. The CDC has a glaucoma initiative. And may I have Mr. Social Worker just read this, please?
Reaching high risk. Identify and engage high-risk people in underserved communities. Provide educational workshops.
Okay. Health education is going to be the most important part of what we need to do. And this can be done and can be multiplied using digital devices, fortunately. So these are the strategies. You need a team approach. You need the stakeholders plus healthcare workers. My time is running out, so I'm just going to run through some of these. But it was really working here at Harlem Hospital that I discovered the high risk of blindness. This article that I published in '79, I got the opportunity to publish again in 1990 because Hopkins failed to cite my earlier work. But the bottom line is there's preventable blindness. Let's go to, this is the one I want you to look at. This prevalence data came in 2010, but I want you to look at the fact that at the age group of 75 to 79, we're practically 4 times the prevalence of glaucoma. Black women are at risk. Why? Well, we're going to be the dominant number in the older age group, plus the racial factors that translates into a greater risk of glaucoma. And this is some of the data that I got before when I was a resident here. To screen and not to screen. And this is what we'll probably talk about in the afternoon breakout sessions, because the USPSTF and the ACHRQ have come up with some protocols that do not wish to fund screening. Mr. Social Worker, you don't read that?
Sure. Older African Americans have a higher prevalence of glaucoma and perhaps a more rapid disease progression. If screening reduces vision impairment, then African Americans would probably have a greater absolute benefit than whites.
So I want to say that these are the conclusions of those groups, and those are their exact words. They don't say that's why we don't want to fund, but that was the conclusion. The American Academy of Ophthalmology has disputed the findings of those two national groups. They have said that yes, we do need screening. Yes, we do need the funding for screening. So it's a battle for health care. It's a battle for resources, and you already know that. If you're in the Harlem community, you know you have to fight for your health care rights. And thank you very much.